Hi, everyone. My name is Dr. Alice DiFrancesco. I'm a board-certified anesthesiologist, and I specialize in regional anesthesia and pain medicine, but I work in many different ORs doing many different types of cases. My primary practice is at Hartford Hospital. Our practice is Integrated Anesthesia Associates, and I work a lot at the main Hartford Hospital and then the Bone and Joint Institute, where we do a lot of orthopedic cases. So like Sydney mentioned, I'll be talking about two different topics, both very relevant to perioperative care, the implications of GLP-1 receptor agonists and marijuana. So this is today's agenda. We'll go over GLP-1 receptor agonists, why they matter in anesthesia and perioperative care. And then we'll go into overview and trends of marijuana use, and then similarly talk about marijuana use and its implications for anesthesia and perioperative care. And then we'll finish with any questions and any discussion. So the first thing we'll talk about is the overview of the GLP-1 receptor agonists. So GLP refers to glucagon-like peptide. It is produced in the small intestine. It has several roles in glucose homeostasis, including increasing insulin secretion, reducing food intake, and reducing glucagon secretion after meals. One of the most important things for anesthesiologists and perioperatively, and why this is starred here, is that it slows gastric emptying. So why it's highlighted and why it's so important to us is because as anesthesiologists, this is what we're most concerned about, is its effect on the ability of the stomach to empty. A little more information about GLP-1 is that it is broken down by the enzyme DPP4. There are other types of diabetic medications that influence the enzyme DPP4, but we won't go into that today. One of the important things that I think should be mentioned is that GLP-1 in vivo is broken down very quickly by DPP4, but the synthetic agonists that we see our patients on are resistant to breakdown by the DPP4, which is why, which explains the pharmacokinetics of the drug. The clinical use of the GLP-1 agonists, primarily it was developed for the treatment of type 2 diabetes. Benefit has also been shown in patients with type 2 diabetes and coexisting cardiovascular disease and/or kidney disease, which we commonly see in a lot of our patients with diabetes, long-standing diabetes, poorly controlled diabetes, is that they most likely have some coexisting cardiovascular disease or kidney disease. The drugs have rapidly gained popularity in the treatment of obesity, whether or not the patient has coexisting diabetes. So this is what we're primarily seeing when the patients come into our pre-op areas or to our pre-op clinics, is that a lot of them are using it whether or not they do have diabetes. And one of the things that we have to be cognizant of is if they are getting it from a physician or if they're getting it from online, if they're getting it, there's multiple like wellness stores that sell it. So even if the drug isn't listed in the patient's pre-op medicines, I ask them directly if they're taking any medications that work in a similar way, or if they're using any injection medications to help with weight loss, because even if it's not prescribed, it's obviously going to work the same way and slow their gastric emptying. And importantly too, if they're not taking it from a physician and we don't know about it, and we've seen them in the pre-op clinic, if we don't know that they're taking it, they probably haven't gotten the instructions on how to fast before they come in for surgery. So it's almost even more important to go over specifically if they're using those types of medications. The drug was approved in 2005 for the use in diabetes. But like I said, it's mostly what we've seen recently is that it's been used a lot in obesity. It was recently approved actually for that use, and patients with obesity, they've been shown to lose up to 20% of their weight. So it is a good drug, we just have to be cognizant. And there are several different agents that are currently in clinical use. Almost all of the current agents in use are subcutaneous injections. There's one medication that's an oral formulation, which I actually didn't realize until recently, because like I said, when I ask the patients if they're taking any of the medications, they'll usually say it by its trade name because there's so many commercials and they'll recognize it more easily if I say, are you taking Ozempic or something like that. Before I was saying, are you taking any injection medications? But once I realized that there was an oral formulation, I had to be a little bit more specific to find out what they were taking. So like I said, there are several different agents currently in clinical use. Each medication has its own pharmacokinetics. Each medication has its own different half-life. This just becomes important to us when we're considering the clinical effects. Like I mentioned, is the gastric emptying, which is what we're worried about in anesthesia. So now I'll go more specifically into the GLP-1 receptor agonist and anesthesia. So when we induce anesthesia, whether it's general anesthesia, whether it's monitored anesthesia care, referred to as MAC or sedation, what we're doing is essentially relaxing the pharyngeal muscles and reducing the reflective and protective responses of the patient, which creates an aspiration risk. So a lot of times what I've seen is we say, we're sorry, the patient ate dinner last night, we can't proceed. And then they say, why can't you just do sedation? And it's definitely worse than to just do sedation because the patient won't have a protected airway. In most cases, in elective surgery, you would cancel it, but in other cases, you would just take more precaution when you're inducing anesthesia. But when you're, like I said, when you're inducing anesthesia and you're relaxing all those muscles, relaxing the protective responses, if something comes up, then it wouldn't be the same as someone who's awake being able to cough and prevent that from going into their lungs. So we in anesthesia have very well established guidelines for NPO times prior to elective surgeries to reduce this risk of aspiration. And I say elective surgeries because if it's an emergent surgery, it's going to proceed no matter what. We just have to take precautionary measures, whether the patient has eaten 1 minute ago or 1 hour ago. If it's an emergency, it has to go. There are different guidelines for different types of PO intake. So if we have a patient who comes in and says, oh, I had coffee with cream this morning, anything fat containing is an 8-hour NPO guideline. There's different guidelines for breast milk, there's different guidelines for formula, there's different guidelines for light meals, which is kind of dependent on the anesthesiologist what they decide is a light meal, but something like toast or crackers might just be 6 hours. But aspiration is obviously very important to us as anesthesiologists. It's uncommon, but it's a very, very serious risk of anesthesia. It's something that we are always thinking about, always wanting to avoid. So of the aspiration events described in the 2021 ASA closed claims analysis, ASA is American Society of Anesthesiologists, the 57% of aspiration incidents resulted in death and another 15% resulted in permanent severe injury. So the rationale for preoperative fasting is to minimize gastric content. Therefore, you would lower the risk of regurgitation and subsequent pulmonary aspiration. There are some things that you can do. So say it was an emergency case and you had to proceed and the patient had just eaten. There are things you can do to reduce the acidity of the stomach. There are things you can do to prevent like putting air in the stomach when you're inducing anesthesia, all the things that we try to do to prevent injury related to aspiration so that if the aspiration does occur, hopefully the effect is less severe. But as you can tell from this ASA closed claims, it's a pretty serious risk and it's very devastating if it does happen. So as I've mentioned multiple times now, the GLP-1 medications to slow the rate of gastric emptying, so thereby it affects the necessary NPO times. According to recent data, about 1 in 8 adults are now taking GLP-1 medications, and like I mentioned, it may even be more than that because of the medications that they can get from wellness stores like in the mall. They can order it on Amazon, they can order it really online anywhere, so it may be even more than we think. So I have been an anesthesiologist now for 2 years, and I've seen changes in the guidelines myself just because the medication is so new. There have been like multiple phases of people trying to figure out the best way to reduce the risk related to these medications in anesthesia. So when I first started, the guideline was to hold the medication for 1 week, and then patients could eat normally, just be NPO at midnight when they're coming in for your elective surgery. But when they looked at that, they realized it doesn't really make sense because like I mentioned, the GLP-1 receptor agonist that are synthetic are very resistant to the breakdown by that enzyme that clears it. And I also mentioned that the different medications have different pharmacokinetics, but when you look at it, the medication's half-life is usually between 5 and 7 days. So I think at first they thought, well, if we hold it for a week, then we're reducing the medication by maybe half. But when you look at pharmacokinetics, to reduce the effect completely, you need 4 half-lives. So that's 4 weeks. It's not 1 week. And it could be different. So there's one medication that the half-life is 5 days. So then it would be 20 days. But it's common too now with the updated guidelines that patients will come in and say, well, I held the medication for 2 weeks. And unfortunately, we can't proceed if it's an elective surgery because it's still affecting the gastric emptying. And we just have no idea really what is remaining in the stomach and how much is being cleared out after the patient had a full meal the night before. So the new guidelines and the things that we follow at my hospital is that the patient should continue taking their GLP-1 receptor agonist perioperatively without interruption. And I think that was important too because patients are not just on it for weight loss, they're also on it for diabetes. And they're also on it, like I mentioned, to reduce the risk of cardiovascular disease. It helps with kidney disease. So if we're interrupting these medications for a week, are we affecting their diabetic control? Are we affecting their cardiovascular risk? Are we affecting their kidney disease risk? And that's not really fair to ask them to hold the medication for a week to come in for an elective surgery. So we tell them to please continue taking the medication because if they were to hold it, we would need it to be for a month anyway, which is quite unreasonable to ask someone to do that. And we ask them to follow a clear liquid diet for the 24 hours preceding their surgery. So the NPO guidelines for clears is 2 hours, which has actually changed a lot even since I was a medical student, since I was shadowing, was you cannot have anything at all after midnight. But now when patients come in, we encourage them to have a Gatorade in the morning. We encourage them to have a little bit of water. We even tell them that they can have a black coffee, which I think is a little bit of a well-kept secret. I'm a big coffee drinker, so I kind of feel bad when patients come in and say, oh, I have such a headache from not having caffeine. And I'm like, well, you kind of could have had black coffee, but we just like to avoid any confusion, I think is why we say that. But you can have clear liquids up to 2 hours prior to surgery. So I think that was the rationale of saying, okay, have a clear liquid diet. Even if you were to have some of that remaining in your stomach, and if a little bit of a clear liquid came up, maybe it's less devastating than if a whole meal came up. But I think importantly, this is kind of strict at our hospital, is that any patient on a GLP-1 needs to be on a clear liquid diet for 24 hours prior to any elective surgery. So it's not really the guideline, it sort of is the guideline, and I think we just do it in the hospital for a clear-cut guideline, and just so that for ease of telling patients is not to confuse anybody, is because really that recommendation is for patients at high risk of aspiration and high risk of a delayed gastric emptying. So just the medication alone, you're at a higher risk of delayed gastric emptying, but there are other factors that might increase your risk even more. So things like obesity, things like severely poorly controlled diabetes, which has its own effects on gastric emptying. But then it kind of becomes a little wishy-washy, whereas I might feel differently about a patient that's high risk as another anesthesiologist, and we don't follow patients, so I can be taking care of someone different than I would have thought I was taking care of the night before. So I think that's why we have these clear-cut guidelines in the hospital that any patient needs to be on the clear liquid diet. But I think another important thing too, and things that I'll ask my patients if they follow the clear liquid diet, just to make sure that they're appropriate to proceed, is if they're having any nausea, if they're having any vomiting, if they're having any bloating, fullness, burping, belching, then that kind of raises a red flag for me that even if they follow this clear liquid diet, maybe they're not completely empty of whatever's in their stomach and they feel a little full still. Most of the patients though, they don't have these symptoms. And I think the other thing that is important too is when they started the medication and if they've had a recent dosage increase. So those patients are at higher risk of having delayed gastric emptying if they just recently started the medication or if they were recently increased the dose. The other thing that we could do is ultrasound their stomach. So it's sort of a newer technique in anesthesia where we do gastric ultrasound. We use a curvilinear probe, we place it on the middle of their stomach and we can see the stomach, and if it's completely collapsed, then we're more confident that it's empty. If it's any sort of like artifact in there is what we would call it, then I'm more concerned. I had a patient recently who was on a GLP-1. She came in for an elective surgery, but she got differing recommendations from her surgeon's office and from our perioperative clinic. So that sort of puts me in a little bit of a difficult position because I feel bad. Like, she's coming for this surgery. She's been technically NPO. She's looking forward to her elective surgery, but she's gotten these kind of contradictory guidelines. So at first I was like, well, it's not been 24 hours, so I don't think we can proceed. It's not safe. But she was like, it's only a couple grapes. Like, I swear it was just a couple grapes at 5:00 p.m. And at this point it was 12. So I was like, ugh, okay, like that's such a small amount of food. Like, I guess we can proceed. But then I was like, I just need you to understand that compared to someone who doesn't take this medication, you're at a higher risk of whatever's in your stomach coming up. So then I tried to ask her the things like, are you nauseous? Are you full? She wasn't feeling any of that, but then she did have a recent dose increase. So the more I talked to her, the more I was like, I don't know. And then she was getting nervous because as an informed consent, I have to tell her, listen, you're at a higher risk. I think we can proceed. If you want to proceed, then we can, but I just need you to understand. So she was getting nervous. I was like, let me just ultrasound your stomach. So her stomach was full. So I'm glad we did not proceed. So it's tough when that happens because I feel bad when patients get contradictory information, and she's here for her surgery. She's ready to go. If I hadn't ultrasound her stomach, I would have felt okay doing it. It would have been just a sedation case because it was such a small amount of food. But once I ultrasound her stomach, I was like, oh no, sorry, we're not doing this. So I think that's an important tool that a lot of anesthesiologists may not utilize. It definitely is difficult to see the stomach sometimes, but I think it's important to remember that we can use that and have a little bit more data going forward. And that kind of just emphasizes that the goal for us is a safe anesthetic for the patient, but we don't want to unnecessarily cancel everybody. So that was my thought process when I was going through in my head proceeding with the case, but I'm glad that I looked at her stomach with the ultrasound. At our institution, we're fortunate that we have a perioperative clinic. Like I said, I work at the Bone and Joint Institute a lot. Almost every patient that comes in for their elective orthopedic surgery there is seen at the perioperative clinic. And they're great about letting all the patients know you have to be on a 24-hour clear liquid diet, and almost never is a patient not on it. I think one of the things that we have to remember as perioperative providers and anesthesiologists is that the surgeons might not know that. And I think it's important that we communicate with them, because the two cases that I can think of recently that the patient didn't follow the clear liquid diet was they had been told by the perioperative clinic, but then someone from the surgeon office called and said, oh no, you can eat until midnight. So just making sure that everyone's on the same page and understands the guidelines. Any questions so far about the GLP-1s? Because we're going to move on to marijuana now. Yeah.
Do the ultrasound very often, or is that just something you get at 5?
I don't do it very often. It's just like I actually wasn't even going to do it on. I don't know. It was just something sparkling, and I was like, those might be the grapes that you ate, and we're not going to do this. I was trying to talk to the patient and sort of just be like, I think you're okay, which that might have just been hubris on my part, thinking that she was okay. But in my head, I was like, I really don't want to cancel her because I feel badly. The surgeon's office told her that she could eat. The perioperative clinic told her that she couldn't. Now she's here. She's been waiting all morning. And she says that she has a small amount of food. And then I was like, you are at a higher risk. And she was like, I don't want to die. I don't want to die. And I was like, okay, let me just ultrasound your, like, it's okay. Let me just ultrasound your stomach. In my head, I was like, oh, it's going to be empty and she's going to feel better. And then I put it on and I was like, oh, we're not going to do this. But I think I often forget that we can do gastric ultrasound, which is funny as a regional anesthesiologist because I use an ultrasound every single day. It's just not something that we did very often, even when I was a resident. They just added it to our board examination that we have to know how to do gastric ultrasound, so it's a very new technique. But I think it's something that we can use more often.
The prescription GLP-1s differ from what you can get online or from Row or these other types of programs?
Yeah, so I am not 100% sure, to be honest. I think that the ones that are sold online and in wellness stores are not as regulated. And what I've seen too is that a lot of them are mixed. It would be two different GLP-1 agents mixed together, which we have no idea what those pharmacokinetics would be. It could worsen gastric emptying. It could last longer.
But they would be getting those through a pharmaceutical company, right?
I don't think so.
Like FDA.
Yeah, so I don't know who's making them. I don't know where they're coming from, but that's why I said it's just important to ask, because I've seen cases where it's not listed on the patient's medication list, and then the anesthesiologist asks like, oh, do you take any weight loss meds? And they're like, oh yeah, I took this one I got online last night. So that wasn't good. That was canceled. But yeah, I think they're just less regulated. I'm not sure who's compounding them or how they're compounding them, so just definitely have to be careful with those. All right, so now we can go on to marijuana. So just an overview and trends of marijuana use. So marijuana comes from the plant Cannabis sativa. The effects of marijuana are a result of delta-9 tetrahydrocannabinol, or THC. THC is a psychoactive substance. It works by depressing neuronal excitability. Basically, to put it simply, marijuana use has increased, which I don't think any of us are surprised by. There is very good data actually from Monitoring the Future panel. This is out of the University of Michigan. It gathers longitudinal data using annual surveys and participants aged 18 through 65. The data dates back to 1986 until today. They currently have more than 120,000 participants, and they're funded by the National Institute on Drug Abuse. So according to the data from 2023, it's at an all-time high, which, like I said, I don't think we're very surprised by. It's the third most prevalent substance used in adults aged 35 to 65. Use, whether it's in the past 12 months, in the past 30 days, or daily use among adults aged 35 to 50 has reached historic peaks in 2023. Daily use has significantly increased over the past 5 years and 10 years. And then vaping as well has remained at or near all-time high levels. Nearly 1/5 of midlife adults aged 55 to 65 reported using cannabis in the past 12 months. They don't have a lot of data for patients who are much older than 65, which I would like to see, because a lot of the patients that we do take care of are older patients. But I think that the data point on 1/5 of midlife adults using it, maybe we can extrapolate and assume that even older adults are using it as well. But they do mention that the leading substance in adults who are older is alcohol. Importantly, as with everything else, these numbers may be an underrepresentation. People might be unlikely to report their use. I think it's less likely in today's world where marijuana is legal now. It's kind of less of a stigma surrounding marijuana use, so people might be more forthcoming with what they're using. I think one of the important things as perioperative providers and anesthesiologists is that I don't care what you're doing, I just have to know. So a lot of times if I can tell that patients are resistant to telling me, I try to just let them know that I'm not a cop, I'm not judging you, I just have to know because it affects how I'm going to take care of you in the operating room. All of the substances affect our anesthesia gases, they affect our anesthesia IV medications, they affect the induction of anesthesia, the maintenance of anesthesia, recovery from anesthesia, pain control. So I just try to let them know that I'm not judging, I just have to know to take the best care of you. I kind of mentioned briefly that alcohol use is a little bit higher in older adults. It's actually the most prevalent substance use in any age group, followed by nicotine and then marijuana. I'm interested to see if that will change as marijuana becomes less stigmatized and legalized everywhere, if that'll be higher than nicotine or even higher than alcohol. Oh, sorry, go ahead. Yeah. Thank you for that lead-in. So CBD or cannabidiol is also derived from the cannabis plant. So this may also be encountered in the perioperative period. It's considered non-intoxicating, so it doesn't have the same psychoactive effects as THC. Its use clinically has been actually extensively studied, mostly in seizures and neuropathic pain and anxiety and depression and sleep. Basically, it has shown that it has anticonvulsant properties and can be useful in treating pain due to neuropathy or inflammation, which I think, as an aside, is important because neuropathic pain is quite hard to treat. It's generally not relevant to our anesthetic practice, but I put a ... there because the CBD itself doesn't really affect our anesthetic practice because a lot of the effects that we are worried about in anesthesia is related to the THC. But similar to the GLP ones that might be compounded outside of FDA regulations or in pharmaceuticals is that we don't know what the CBD is being compounded with. So some of the more important ones are dextromethorphan, which is a cough medicine. There can be some synthetic cannabinoids in the CBD, which definitely have a big risk for anesthesia, which I'll get more into in a little bit. And the dextromethorphan or the cough medicine can have actually hallucinogenic effects, which is why it's regulated when you buy it over the counter. So if people are drinking cough syrup, it's like, to get high from the hallucinogenic effects. So if the CBD is mixed with that, then obviously we're more worried than if the CBD is just CBD alone, which wouldn't really affect our anesthetic at all.
Can I ask a question?
Mm-hmm.
When we're talking about marijuana use and THC, is it also inclusive of what you can buy in a can now? To 9?
Yeah. So I think it's hard, and I would treat that as being the same effect as smoking or vaping it, just because we don't know. And they have the drinks that have the THC. Hopefully that wouldn't be as relevant because hopefully they're not drinking THC drinks on the day of surgery. But yeah, there's a lot of different products now that we have to kind of be worried about. Yeah, it could be clear. They're not wrong. They did the clear liquid 2 hours before. But yeah, that's something that we have to think about is there's so many, I can't just ask, are you smoking marijuana? You have to say, are you using marijuana? And then I'll get into it a little bit more, but then how are you using it? Because that has its own different effects. So now I'll talk about marijuana use in anesthesia. So this is just a cool picture I found that I think we forget how much marijuana can actually affect the entire body, whereas people are using it mainly for the neuropsychiatric effects. It actually affects almost every organ in the body. So I thought this was a cool picture to highlight that it has many different effects, and I'll leave it up for a minute. I see people taking pictures. So, oh, I can go back, sorry. I'll just start talking about the next slide while we're waiting. So I think when you're looking at a patient holistically and they come in to the pre-op area before they're about to get anesthesia, my first question, well, not my first question, but if they're acutely on marijuana, that elective surgery is not happening. Obviously, sometimes it's hard to tell because it's not the same as if they had just used cocaine or are clearly intoxicated from alcohol. But sometimes you walk into a patient's pre-op bay and you can smell it. But then that gets a little dicey because who knows when the last time they used it was, and they can tell you that it was yesterday and the smell is just lingering. So at that point, you just have to go through an informed consent pretty clearly. But any patient who is acutely intoxicated, not undergoing elective anesthesia, one, because it has neuropsychiatric effects, so that has implications for an appropriate informed consent. Any patient getting any anesthetic has an informed consent, and it's a whole entire form that we go through. It's separate from the surgery. We have to talk about every type of anesthesia that we're doing, whether it's sedation, whether it's general anesthesia. Are you okay with getting a nerve block? Are you okay with getting a spinal? Are you okay with getting blood products? Are you okay with an arterial line? So if they're under marijuana acutely, obviously they cannot consent. The other thing that is quite important is the cardiovascular toxicity of marijuana, which is something that I think people don't realize. So there are multiple effects actually of THC on the cardiovascular system, mainly related to sympathetic activation. And this is both with acute and long-term use. So basically what THC does is increases circulating catecholamines. So epinephrine, norepinephrine is kind of just coursing throughout. And the acute intoxication or recent use increases the risk of perioperative myocardial infarction, ischemic stroke, or TIA. And in a retrospective study that included more than 27,000 patients, they were undergoing a wide range of elective surgeries, joint replacement, C-section, CABG. The incidence of postoperative MI was significantly higher in patients who were using marijuana. It was basically a 1.3 times higher risk of a perioperative MI compared to someone who wasn't using marijuana or had stopped it in an appropriate time period. I think it is important to note, though, that there was no significant difference in overall morbidity and mortality with and without patients in marijuana use, but obviously a perioperative MI is a huge event and itself carries its own morbidity and mortality. The acute use can also result in cardiac arrhythmias, which can be exacerbated by the induction of anesthesia. So when I'm talking to patients, I think it's important to let them know that undergoing anesthesia is actually a pretty big stress on the heart and the body. What I like to say is that undergoing anesthesia is like running a marathon. So it's the anesthesia and it's also the surgery that really puts your body into this huge fight or flight response. So if you have circulating THC that has increased these catecholamines already, and then you're inducing anesthesia, you're starting a surgery, it's just going to be this huge sympathetic surge that can really cause problems. Another important thing in that study too, underlining the monitoring the future panel, was that in that same study, they had analyzed the prevalence of marijuana use and marijuana use disorder among surgical patients, and it significantly increased. This number was kind of astounding to me. So it increased from 21.1 per 1 million surgical admissions in 2006 to 71. So that's, yeah, it's quite a big increase. So it's just something that we have to be cognizant of. So like we kind of mentioned too, the route of use is important. I actually didn't think about drinking. I would be more concerned about just the circulating THC and the effect on the catecholamines. Really, the route that I'm concerned about is smoking or vaping, because I think the common thought is that smoking or vaping marijuana is safer than smoking or vaping nicotine, but really you're introducing an inhalant into your lungs. So it places you at the same risks of pulmonary side effects similar to nicotine, which I think we have to underline with our patients who we're talking to, because they may think that it's safer and really it's not.
What would the nicotine patch?
So the nicotine itself has its own effects in terms of what it does to the body. So it's a little bit of a stimulant. So if they have a nicotine patch on, I personally wouldn't remove that because I don't want to cause any cravings. It's generally okay. I haven't taken off a nicotine patch for them, for a patient to undergo anesthesia. Obviously, I don't want anything in their mouth. So if there's anything in their mouth, then got to get rid of that. But when I say the pulmonary side effects, it's more of like the secretions, the damage to the lungs, and the ability for us to ventilate the patient, the ability for us to extubate the patient. And when you think about smoking and vaping, whether it's any type of substance, it's going to have an effect on your pulmonary mechanics. So I thought it was interesting actually that the THC itself causes bronchodilation, which might be helpful, but we don't want to use it for that. But any act of smoking or inhaling anything really just causes a lot of irritation of the airways. It can cause swelling of the airways. So that makes my job more difficult if I'm trying to intubate the patient, if I'm doing laryngoscopy and the airways are swollen, if I can't pass an endotracheal tube. You know, that's a cancellation of a surgery, because if I can't get a breathing tube in, then we can't proceed. So I think it's just important to emphasize to patients that it really does have a lot of effects similar to nicotine. And then kind of like I mentioned as well, it could make the ventilating the patient more difficult, which is similar to what we see in patients who smoke cigarettes. And then kind of tying everything together is that marijuana has gastrointestinal symptoms as well. So it can delay gastric emptying, which we do not like. As we talked about earlier, it can really be a big concern for us. And it can also result in nausea, vomiting, and abdominal pain. The other big effect of marijuana is cannabinoid hyperemesis syndrome. So this is a syndrome that results from chronic daily use of marijuana. It's characterized by very severe nausea, severe vomiting, which can lead to dehydration, and electrolyte abnormalities if these episodes of nausea and vomiting are protracted, which those have their own implications for anesthesia, which we won't go into here. But the patients with any recent marijuana use really need to be very clearly evaluated for any GI symptoms, and they may need to be treated as having full stomachs. So that kind of, if you're an elective surgery, again, that might be another reason to delay. If it's an emergency surgery, we would do what's called rapid sequence induction and intubation, which isn't a zero risk of aspiration, but it's a technique used in anesthesia where you pre-oxygenate the patient as much as you can, push the meds very quickly, higher dose of emulsor relaxant, and put the breathing tube in right away without even mask ventilating them, which has its own risks because they could desaturate. That can affect their oxygenation, but if it's an emergency, you have to do what you have to do. Just going back to cannabinoid hyperemesis syndrome, so there's actually evidence that the patients with this syndrome can have an unexpected response to propofol, which has to do with the endogenous cannabinoid receptors. So in our body, we have our own cannabinoid receptors, we have our own endogenous cannabinoids. And obviously propofol is a big drug that we use in anesthesia. I use it every day, multiple times a day. So if I am encountering a patient who's using chronic marijuana or has this nausea and vomiting from the marijuana, then this is something that I just learned creating this presentation, is that I have to be careful of how they're going to react to propofol and what would be my backup plan, because propofols are the mainstay of the drug that we use to induce anesthesia.
What would that reaction be?
So it would kind of just be like a paradoxical reaction. So whereas it may induce anesthesia for someone who doesn't have this syndrome or doesn't use chronic marijuana, it may not induce anesthesia quite the same. They may need a higher dose. They may become more dissociated, and I would probably have to use multiple different agents. And I actually don't know, I wanted to look into it more, was the pharmacokinetics and dynamics of propofol, and if it would it last longer? Would it last less of a time? But yeah, I thought it was very interesting that it kind of affected that. So that we kind of talked about the patients with acute use, chronic use, and both. But in terms of recommendations of undergoing anesthesia and surgery, so if I'm concerned with a patient being acutely intoxicated with marijuana, I would, they say to delay the surgery at least 2 hours. In practice, if a patient's at a surgery center or at a facility where you need to, keep going with the next patient, the surgeon wants to go home, they're probably just going to get canceled. But if it's at like a tertiary care center or a bigger hospital where they may need to be delayed and the next patient's going to go, then we can proceed. I'm not sure how comfortable I feel with a 2-hour time waiting period, especially with the increased risk of MI if it was an elective procedure. Conservatively, I'd probably just cancel the case if they were acutely intoxicated with marijuana. But someone coming in for an urgent or emergent surgery, if you can delay it, it's probably in the best interest of the patient. If you can't delay it, then you just do your best to support them and get them through it. In terms of the cannabinoid hyperemesis syndrome, so if these patients are coming in with intractable nausea and vomiting, delaying any surgery for 24 to 48 hours may allow for symptom improvement, and that way we can induce anesthesia in a safer way than doing the rapid sequence induction like I talked about. Other things in terms of anesthesia, we kind of already mentioned with the propofol, is that they may have altered reactions to the anesthetic medications. Marijuana can kind of work synergistically with some of our medications, or it can prevent our anesthetic gases from working quite as well. So they may need more, they may need less. It just is something that we have to think about while we're doing the case, and that if we think that this is enough for one patient, it might not be enough for this patient. So we just have to be careful while we're taking care of them. And then really being aware of the sympathetic activation associated with marijuana, and then using caution with other medications that increase sympathetic activity. So we use a lot of those medications to increase sympathetic activity. A lot of times when you induce anesthesia, the patients become pretty profoundly hypotensive, and we have medications that increase their blood pressure, increase their heart rate. But we would have to be careful if they had just recently used marijuana, because we might be doubling that effect. Another one too that people don't think about is ketamine. So ketamine is a medication that we use a lot in anesthesia, but it has a lot of sympathetic effects as well. So it's not just the dissociative anesthetic, it works on other receptors as well that increase the heart rate and increase myocardial contractility. And then chronic use of marijuana is associated with higher anesthetic requirements. And they also have increased postoperative pain and opioid requirements, which I think is something that we have to think about as well, especially if we're taking care of them in the PACU, or for someone like me who does regional anesthesia and pain medicine, is that if they're using marijuana, they may benefit even more from a nerve block. They may need more attention after the surgery to treat their pain, and use different types of multimodals to really make sure that their pain is appropriately controlled, whereas someone who's not using marijuana may be okay with one type of medication. Someone who is using marijuana might need several different medications, and just recognizing that we need to treat their pain appropriately. And then in some retrospective studies, patients with current cannabis use disorder have a higher risk of postoperative complications, including respiratory failure. My guess would be that that's most likely related to the smoking and vaping of the marijuana and its effects on the lung integrity. They also have a higher risk of acute kidney injury, MI, stroke, other thromboembolic events, probably related to the sympathetic activation. And there's some data too on the THC affecting coagulation and the ability to break down clot. Interestingly, increased hospital length of stay and hospital readmission are also more likely in patients who are using marijuana. So I think in total, it's just something to think about. Is if someone comes in and says that they're using marijuana, it's a much more global issue than we might have thought about initially. Just a summary. So with GLP-1 receptor agonists and anesthesia, the GLP-1 receptor agonists have multiple effects, most notably for anesthesiologists being the delayed gastric emptying, which can place the patient at risk for aspiration. So in general, a clear liquid diet should be followed 24 hours prior to elective surgery, but just follow and know your hospital's protocol because it might differ widely. And then marijuana use in anesthesia. So marijuana has systemic effects and has implications for anesthesia care. Like we said, marijuana use is rising, and all patients should be evaluated perioperatively for use. And then acute intoxication would be a reason to cancel elective surgeries. At least that's my opinion. And that's it.
What is the half-life of marijuana? I mean, like you smoke a big fatty.
Yeah, I don't know. So that's why the 2 hour recommendation is something that I'm not super comfortable with, because if it's someone who smoked a huge joint versus someone who took one hit, how am I to know how long that's going to last? There probably is better data on what the actual half-life of the THC is. That's something that I should have looked into, but I didn't. But that's why conservatively, my preference would be to cancel an elective surgery, no matter what the route or amount of use was, because I don't know. And then how does it affect the larger man versus the little old lady that I might be taking care of? 2 hours just seems like kind of a stringent guideline when there's so many variables that go into thinking about it.
That could be on your questionnaire, fatty.
Did you use a fatty? But then it's like, what's a fatty to one person and to another? I don't know.
we ever run a talk screen before like an emergency where you're not sure?
So we will often get patients. So a lot of times we'll get trauma patients, and the emergency department, it seems like it's in their protocol that they'll run a talk screen. But at that point, if they have something in their system, I have to do it anyway because it's an emergency. It's good to know. And sometimes you can evaluate the patient too. Like you can look at their eyes, see if they have red eyes. One of the drugs that we're actually most worried about in anesthesia is cocaine. But after reading about marijuana and kind of learning a little bit more about it, it actually kind of has similar effects to cocaine, where the reason we're so worried about cocaine is because of all that sympathetic hyperactivity. But THC has a lot of the same effects. And you know, when you think about, oh, this patient smokes weed, that's probably okay, whatever. But then when you read more about it, you're like, oh, wait, it actually is kind of serious. So yeah, the ED sometimes will run it. If we get a patient who's an elective surgery and we have any concerns, sometimes we'll ask them if they're okay with that. We can't really do it without their permission. And then at that point, it's just a risk-benefit discussion. And like I said, really the most important thing for me is just being honest with the patient and saying, I'm not judging you. I really don't care what you're doing. It's just, I need to know to take better care of you. And then when you kind of phrase it like that and say, like, if I don't know that you just used cocaine and I give you a medication, you could die, and I'm not being dramatic, I'm being serious, then they're usually more forthcoming with what they've been doing. And that helps me to take care of them. Yeah. I don't like saying those words because it feels like I don't want to scare the patient, but you know, anesthesia is serious, surgery is serious. They have to know what they're undergoing, and I don't think sometimes patients, they come in and they don't quite understand that. So if you say very clearly, like, this is a huge risk, I just need to know, then they're usually pretty honest.
So it sounds like the perfect patient is someone who is on a GLP, get the munchies from smoking.
Mm-hmm. Yes. Yeah, that's my favorite. Any other questions? Anything I can go over again? Mhm. Great. Well, thank you guys. Thank you for coming. Thank you for having me. I hope that was helpful. I learned a lot. I hope you learned a lot too.